Hello, everyone. My name is Brian Beshko. I'm the Senior Director of Grants and Partnerships at the Canadian Breast Cancer Foundation. And it is my great pleasure this evening to introduce our next expert speaker at tonight's event, Professor Jacques Simard. Dr. Simard is a professor in the Department of Molecular Medicine at Université Laval and is Deputy Director of Basic Research at the Centre Hospitalier Université de Quebec Research Center. Professor Simard has held a Canada Research Chair in Oncogenetics since 2001 and has authored more than 360 publications, review articles, and book chapters. He is a fellow of the Canadian Academy of Health Sciences, and amongst his many awards, in 1999, he received the most prestigious recognition for a young scientist under 40 from the Endocrine Society, the Richard E. Weitzman Prize. Professor Simard has played a key role in the strategic development of health research as a member of the Medical Research Council of Canada, the Canadian Breast Cancer Research Alliance Management Committee, the Institute Advisory Board of the CIHR Institute of Gender and Health, the Genome Canada Board, and Science Advisory Board to Health Canada. As Director of the Interdisciplinary Health Research International Team on Breast Cancer, Susceptibility, clinical research network including 26 scientists and clinicians from across Canada as well as USA, UK, and France, he has been involved in the discovery of the impact of mutations in susceptibility genes for breast and ovarian cancers, namely BRCA1 and BRCA2. Since 2013, Professor Simard has been the co-lead of a large-scale Genome Quebec, Genome Canada, CIHR, and QBCF-supported project, which Dr. Simard co-leads as part of an international team of 23 co-applicants from Canada, the UK, the US, the Netherlands, and Germany. This project is called Perspective, and as you will hear from him tonight, the purpose of this project is to develop risk stratification and communication tools to increase early detection of breast cancer by extending the current mammography screening programs in an optimally cost-beneficial, targeted manner, especially for young women, i.e. women 35 to 49, with relatively high risk of breast cancer, who are missed by the current standard age-based screening program. So without further ado, Dr. Simard, we welcome you to the podium.
Today, I did take a decision to give you some insight about the current status on research and how we are trying to decipher the inherited susceptibility to breast cancer and how we will use this information to personalize risk stratification for prevention and early detection. As you know, currently, several countries and the European country, the United Kingdom, Canada, they developed some report about personalized healthcare, personalized medicine. Some people speak about precision medicine. In UK, they speak about stratified medicine. And here in Canada, we speak about personalized healthcare. Of course, we speak also about the 4P medicine for personalized, predictive, preventive, participative. And this is meaning that you should include your genetic profile, the environment, lifestyle, medical history, metabolic characteristic, and this will have the hope of a better treatment, adaptive therapeutic solution, reduction of adverse effect, targeted intervention, and increase the efficiency of the healthcare system. I will go quickly on that. You know all these numbers, but one thing which is important to remember, 1 out of 5 cases of breast cancer will be diagnosed in women younger than 50 years old, which usually is the age of eligibility for the age-based mammography screening program in many provinces. More than that, 36% of all cancer diagnosed in women between the age of 30 to 49 years. There are good news. During the last 25 years, the incidence normalized has been always stable to 100 individual per 100,000 people, but the breast cancer mortality rate have fallen by 43% due to increased mammography screening and more efficient therapy, most likely after the surgery, which has been helped by the discovery, early detection by mammography. More recently, a pan-Canadian study of mammographic screening and mortality from breast cancer used data, you have data from Ontario, from Quebec, from all different provinces in Canada. And here you can see that approximately 2.8 million women have participated in these studies between 1990 to 2009. And the average breast cancer mortality among participants was 30% lower than expected, with a range across province between 27 to 59%. Thus, in summary, participation in mammography screening program in Canada was associated with substantially reduced breast cancer mortality. And this is important. And also, we are not speaking about survival. With sometimes when you use women who participate in such studies, you can have some survival bias, but we are speaking about mortality here. Of course, in Ontario, the mammogram are recommended for women aged between 50 to 74 years old. They are benefit, as I mentioned, reduce the risk of dying from breast cancer, reduce, more importantly, the risk of having chemotherapy, because less cancer are detected at advanced stage. And in other words, early detection help to have a stage 1 or a stage 2 breast cancer instead of metastatic breast cancer. But there are risks, there are harms. The concern, anxiety during further tests. A large majority of women, if they are followed during 25 years, will have additional tests to avoid false positive. There are overdiagnosis and overtreatment in such circumstance, and also sometimes they are false positive. No screening method are perfect. And of course, in different countries, including Canada, there are still debate on which screening interval will be most beneficial, and whether younger women, let's say 40 years old women, should have routine screening. And of course, like all other screening, public screening, mammography is more effective in the population with the higher prevalence of the disease. Then our research is built on highly suggested simulation studies of risk stratification. 2 studies have been published from United States. The first one is showing that personalizing mammography by breast density and other risk factors for breast cancer. And their conclusion is biennial mammography for women aged at 40 who have a 2-fold higher than average risk could be cost-effective at current spending standard. Then we are speaking now at 2-fold. Their definition it's sufficient to be cost-effective. Another more recent studies with the title "Tipping the Balance of Benefits and Harms to Favor Screening in Mammography Starting at Age 40" by an international team. Their conclusion is biennial screening with digital mammography at age 40 for higher risk women, and the high risk woman is defined as having a 2-fold, greater than a 2-fold increasing risk above average, will yield to the same ratio of false positive result to life years gain as biennial screening average is a rich woman aged between 50 to 74. I will pass quickly on that because Dr. Metcalf mentioned about the risk, but just what are the risk factors in the 40s, which increase by 2-fold? And of course, it's the first degree relative of breast cancer will increase the risk by more than 2-fold. Having 1 is increasing the risk by 2-fold, and having 2 first degree relative will increase the risk by 3.8-fold. And of course, if the breast cancer is diagnosed before 40 years old, it will increase the risk by 3-fold. And if it's diagnosed before menopausal, it will increase the risk by 2-fold. Another risk factor which is sufficient is breast density BI-RADS category 4, which is approximately 9% of women will have such dense breasts. Then this is not rocket science. We speak about breast density and we speak about family history. And still, it's important to make awareness about these 2 concepts. The Ontario Breast Screening Program, you have a chance. It's always unique in the world. You have a leadership role. It's very rare, if I'm not aware of any other jurisdiction having a high-risk breast screening program routinely based on for high-risk women. And for those briefly, women are eligible for this Ontario breast screening program for high risk. If they have no acute breast symptom, are 30 years old to 69 years old of age, and met the following criteria: being a carrier of a deleterious gene mutation, BRCA1, BRCA2 mainly, are the first-degree relative of a mutation carrier and have declined genetic testing for personal choice, or are determined to be at more than 25% lifetime risk of breast cancer, which is a concept which is maybe not the best one, because a lifetime risk, usually in a woman of 30 years old or 55 years old, it's not meaning the same thing. Then I will encourage people to think maybe a 10 years risk of developing breast cancer as something much more accurate to discriminate. Anyway, this is the criteria. I've received a chest radiation before the age 30 and during the at least 8 years previously. Then this is the in some respect, the risk-based approach. And an editorial was also published just after the previous paper that I mentioned to you. And the editorial was, I like the title, Risk-Based Mammography Screening, an effort to maximize the benefit and minimize the harms. Then you understand that we speak about risk-based mammography screening in contrast to age-based mammography screening, which the age is the main criteria. Then currently, risk stratification is based on family history or rare mutation in BRCA1, BRCA2, which correspond approximately of less than 1% of women in the general population, which are estimated to be at high risk. This is what is currently available. Women at high risk develop breast cancer at an earlier age, and frequently these cancers tend to be more aggressive than breast cancer diagnosed in women at average risk. In our project, we believe that at the end, the risk profiling developed through this international endeavor will increase the proportion of identifiable high-risk women by more than tenfold. And personalized risk stratification will extend the current screening program in a cost-beneficial manner, especially for younger women, let's say between 35 to 49 years old, at higher risk, who are missed currently by standard age-based screening approach. Then our research strategy, which is funded by the Genome Canada, the Quebec Breast Cancer Foundation, the CIHR, the NCI, and Genome Quebec, is quite simple. The goal is to increase early detection of breast cancer by extending the current mammography screening program in an optimally cost-beneficial and targeted manner, especially for younger women at higher risk. This will be achieved through a determination of a genetic risk profile, which will be incorporated into a risk prediction model and taking into account with other non-genetic risk factors in order to increase the proportion of women identifiable in the high-risk category. Then we are speaking about personalized risk assessment here. This is an integrated picture about our program. There are 6 different activities, different groups. As Brian mentioned, then we have more than 26 key investigators involved. I have the chance to be the lead of this project. And of course, the first component is to the risk identification and the determination of the genetic risk profile. We will speak later about the different type of genetic variation. The second aspect will be the risk profiling. It's to develop a clinical service genetic test in an accredited lab, and we are collaborating with Dr. Susan Camel-Reed and Irene Androulis here in Toronto for such endeavor. It's critical. And the key deliverable of our project will be a risk prediction model. Then the goal is to use a comprehensive risk prediction tool, which will take into account the genetic and non-genetic risk factor, and how we can improve the performance of the algorithm. And we will also validate in a prospective cohort the accuracy of this. And one of these prospective cohort will be the Ontario Breast Cancer Familial Registry. And we'll have more than 15 years of prospective information to be sure that the accuracy of this new risk prediction model. The risk management also, I have the chance to collaborate with many scientists. Nicole Mittman here in Toronto, collaborating with the lead of these activities, Michael Wolfson, who is professor at the University of Ottawa, and other scientists in Quebec. The goal is really to make a risk management model, and this is to develop a building on what they call the Canadian Partnership Against Cancer. They just released, or they will release soon, the cancer risk management model for breast cancer, and we will, Dr. Wilson and his team will add the genetic component in this model, and this will be important to develop some scenario about to determine the best threshold, at which age we should start the mammography, at which interval, which type of resource we will need, and how many human power we'll need. And more importantly, we have more than 20 people working on the risk stratification and communication. This is crucial. Then we are developing a risk stratification and communication toolbox, which will help both the health professional, the public, and the decision maker to work on this respect. Then we have the chance to collaborate and to work with the largest, the Breast Cancer Association Consortium. This brings more than 90 studies around the world. This brings approximately 200,000 samples, but the update is more than 300,000 samples now we have access from 36 countries. This is a huge advantage that everybody across the world put their data together. Then today, Dr. Metcalf and a lot of you are well aware about the rare variant risk, high risk, BRCA1, BRCA2, and some other gene. There are also new genes which are currently discovered, which are rare variant also, but they have a moderate risk. They increase the risk by, I will say, 1.5, 2.5-fold, 3-fold sometimes. BALB2, CHIK2, the recently discovered gene from the group in Toronto here, REC-HEL, is also a rare variant, but also increase the risk. But today I would would like to focus a little bit on the common variant of low risk. We discover hundreds of these new markers, and these are discovered in women with or without family history. Some of these markers increase the risk a little bit, slightly, increase the risk by 5%, 10%, 20%, 30%, and they act multiplicatively. Some of these markers prevent or decrease the risk, and some other will increase the risk. It's important, but using this information, we can build a genomic profile, a genomic signature, and this is crucial, and this will help for a personalized risk assessment. Currently, then BRCA1, BRCA2 explain approximately 20% of the genetic variants of breast cancer risk. The other genes which are known explain approximately 5%, and the common SNP, the common polymorphism. When I'm saying common, for example, sometimes the first SNP which has been discovered increased the risk by 28%, 30%, and approximately 38% of women has this polymorphism. 15% of women has a 2 copy, and just one polymorphism increased the risk by 60 to 80% of developing estrogen receptor positive breast cancer. Then currently we discover hundreds of these markers, and we know from a previous study performed by during the last few years that maybe we can explain another 14%. Then let's say that approximately half of the genetic variants now is known. I think it's important to well understand, when we speak about hereditary breast cancer, usually among us, we speak about BRCA1, BRCA2, P53, then we say that genetic is involved in 5 to 10% of breast cancer. But I hope that you understand now, in fact, that genetic is involved in almost the large majority of breast cancer, because all women will have some of these genetic markers, which are quite frequent. Then it's a different concept. We are speaking about a polygenic risk model. Then just during the last year, through our project, then we bring more than 40 countries, hundreds of research teams. We just complete the analysis of 150,000 participants, half case, approximately a little bit more case than control. And we are collaborating with other international groups on that. At the end, we will be able, most likely, to make a combined analysis with maybe 250,000 women. It's crucial to have this large number of women because we would like to have a precision on the genetic marker, these common variants, because they are increasing slightly the risk, then it's important. And usually when we select one of these markers, it's because we have less than 5 chances out of 100 million to make a mistake, okay? Then it's not like usual 1 chance in 100. It's approximately 1 chance or 5 chances less than 100 million. Then we build a tool, the OncoArray, and this is like a microscope slide, and we can put the DNA of 24 individuals on this slide, and we can analyze simultaneously the 24 individual, more than 500,000 markers. We developed that, we designed that slide, and we've completed the genotyping of last year about this. And we collaborate, and after our grant, our colleague in United States built that. Then we use the same slide, the same tool to characterize for prostate cancer, ovarian cancer, lung cancer, and colorectal cancer. And we also genotype more than 30,000 BRCA1 and BRCA2 carrier. Then we are doing currently the analysis of the genomic data. This should be complete by this year. And we are integrating this genetic information with the medical history, tumor pathology, treatment response, environment, and family history. Then, this is what, when we speak about genetic risk assessment, it's taking the genetic risk profile of all different variants, BRCA1, BRCA2, CHEK2, BALB2, and the genomic signature developed with the 100 marker. The family history of cancer, the demographic data, the mammographic density, and other non-genetic risk factors like alcohol consumption, diet, BMI, etc. Then we include this, and through a risk prediction model, then we can determine a personalized risk assessment. Currently, for the risk stratification, all women are in some respects similar, except here in Ontario you have the high-risk program, but in general it's like this, and then the mammography screening will start at 50 years old. Using the risk stratification, then you will be able to provide a more precise risk assessment, and some women will have a risk sufficiently high to be screened, earlier than starting maybe at 35 years old or 30 or 40 years old, depending upon the level of the risk. And this is the concept of the risk stratification. When you reach a certain threshold, then it's to be cost-effective mammography screening, then you can be eligible for such a screening. This is real data, which has been published a month ago, using 90,000 women, and this is. I will just go there. And you can see here, if you can stratify into 5 different risk groups, then here you have the 20% of women with the lower risk, as determined with using just the common variant, the 77 SNP. Now we have a better, because we know we have discovered hundreds of them now. And the 20% without a family history will have a 5.2% probability to develop breast cancer before the age of 80. In the 20% having the highest risk, then this risk will be 16.6%. When you have a family history at the first degree relative, then the risk of the 20% lower category will be 8.6 versus close to 24% in the high risk category. Here, it's the 10 years probability to develop breast cancer in the next 10 years. Then here, the red line is the threshold usually used for the eligibility for a breast screening program, then having approximately 2.4, 2.5% probability to develop breast cancer in the next 10 years. It's normal that this arrive approximately at 50 years old. These data are from UK, and it's arrived at 47 years old. But here you can see that if you take if you can identify the 20% of women with the highest risk using just the 77 polygenic risk score, okay, then you can see that this group of people will reach the threshold at 37 years old. And of course, here, when you have a family history, and if you can use this information, you observe that almost 80% of these group with family history will reach the threshold before 40 years old. And this is an example about a more precise risk assessment. Then, what is the impact of the risk stratification? Quickly, personalized risk stratification will extend the current screening program in a cost-beneficial manner. Of course, we have still demonstration to do, but this is the evidence currently. The risk profiling developed by the end of our project, we mean in the next 2-3 years, will have the potential to increase by tenfold the proportion of identifiable high-risk women with a risk, and this is the definition of our definition of high-risk woman, having a risk greater than threefold than the population average, which means approximately 1 chance out of 3 to develop breast cancer. The risk stratification of women has the potential to offer a rationalization of current mammography screening, with the interval of screening adapt according to the risk for women aged between 50 to 74 years old, especially for high-risk women. For example, if you are at highest risk, then you can have an annual screening instead of a biennial screening. And of course, early detection and follow-up will improve survival, we hope, reduce invasive treatment, improve quality of life, and reduce the cost of the treatment. Because as a recent study performed here in Ontario by Nicole Mittman and Craig Hurl and their colleague, it's clear that the cost of treating a breast cancer at stage 1 is quite different. It's in fact almost more than 2.5-fold lower than metastatic breast cancer. There are other impacts. Some people speak about Arimidex or other tamoxifen chemoprevention. Then, of course, the role of these treatments has been established. And for example, in UK, but in different jurisdictions, but in UK, they recently updated their cancer prevention guideline for women who are at higher risk. And they recommend that women who have a strong family history of breast cancer, but who have not been diagnosed with the disease, be offered a 5 years chemoprevention with tamoxifen or raloxifene. Several other agents, such as aromatase inhibitor, are currently being investigated in randomized trial. However, all these agents has potential adverse effects, which include an impact on the quality of life. Therefore, their acceptability and cost effectiveness will be greatest among women at higher risk. Moreover, the risk stratification could allow MRI screening, which is currently recommended for BRCA1 and BRCA2 mutation carrier. In some jurisdictions, they said that women having a 25% lifetime risk, it can be eligible for MRI. And 25% lifetime risk is approximately 2.2-fold relative risk. Then if we say that in our project, high risk is threefold, then they can be eligible, like other women. And this can help to ensure efficient early detection of breast cancer, especially in younger women with breast density. Moreover, an adjunctive test based on genomic profiling might also increase the uptake of existing screening method and risk reduction, prevention, intervention, especially at high-risk women. More interestingly, lifestyle change, when we speak about modifiable factor, can also have an important contribution to lowering the risk of developing breast cancer. These modifiable factors include weight reduction, physical exercise, alcohol consumption, hormonal replacement therapy. Currently, the analysis performed in our international consortium suggests that the effect of genetic factor and lifestyle risk factor on breast cancer risk are multiplicative. This suggests that a change in modifiable factor will have the greatest absolute benefit, as well as being the most acceptable in women at highest risk. Something interesting also, which we have a special consortium working just on this respect, the SIMBA consortium. We demonstrate that there are also modifiers which change several known genetic markers, several common susceptibility alleles will have shown to modify the breast cancer and ovarian cancer risk in BRCA1 and BRCA2 mutation carrier. And because BRCA1 and BRCA2 mutation carrier are already at elevated risk of developing breast cancer, then these modifiers result in an even higher, bigger difference in the absolute risk. Then this is really some advantage of using a polygenic score. And such difference could be informative for genetic counseling process. For example, as you can see here, using just the modifier that we have discovered during the last 7 years, then you can discriminate, for example, the 10% at higher risk in BRCA1 carrier, okay, which has approximately 79, 80% to 100% risk of developing breast cancer, compared to the 10% of women with the lowest risk, based on the information of the polygenic risk score on common variant. Then this usually, when in genetic counseling, currently they use the blue line as the average, and But now in the future, in the near future, we can be able to discriminate, or at least a proportion of women being at lower risk compared to those with a higher risk. And this is also true for the ovarian cancer. Then this is something which should be taken into consideration very soon in the clinical context. And finally, the large majority of women testing for BRCA1 and BRCA2 test negative or are uninformative or inconclusive and receive more or less the same risk estimate on the basis of their family history. Then an extended Bodacia model, which is the current model that is used in the genetic counseling for a high-risk clinic, but now it will be including all the genetic variant, including the non-genetic factor, will be used for personalized into a more distinct risk class. Clinical geneticists will quickly recognize the increased power of this tool and will have their counseling practice. It will allow healthcare providers to make a more rational decision about the use of panel testing and individualized risk prediction. Moreover, many women currently considered at high risk will be given lower risk estimate, potentially sparing them an unnecessary intervention. Then I would like to thank my colleague. There are several colleagues from Ontario, Dr. Irene Andrulis, Dr. Gary Bader on the bioinformatics side, Dr. Hannah Chiarelli of the Cancer Care Ontario. I have also Gord Glendon from in the group of working in close collaboration with Irene Andrulis, and Dr. Suzelle Kamel-Reed and Dr. Nicole Mittman from Ontario. And also my key collaborator, Doug Easton, Antonis Antoniou from the University of Cambridge, Dr. Bartak Knopper, who is the co-lead, especially on the ethical, legal, and social issue and risk communication toolbox, and other clinicians. Thanks, and my colleague from the Breast Cancer Association Consortium, and from the Consortium of Investigator of Modifier BRCA1, BRCA2. Thanks for your time.
We have time for 2 questions.
This question comes from Twitter, from Beth in Spain, who's following along. And she wants to know if there's any investigation regarding the link between ER-positive breast cancer and long-term use of hormonal contraception, because she was on hormonal contraception for a long time, and she now has stage 4 ER-positive breast cancer, and she's wondering if there's any known link between the oral contraceptives and cancer.
This is a difficult question to answer because we know that oral contraceptives, there are many types, and depending upon which years also, which type of oral contraceptive has been used, the duration also. But we know that it's slightly increasing the risk depending upon the type. And it's difficult to give a clear answer about this. We know that, for example, when I was speaking about the common genetic variant, some of them are associated with an increasing risk of, for example, estrogen receptor positive. Some of them are specific for estrogen receptor negative. Then we have a current program which is just funded from the European Union in the Horizon 2020, and it will be specifically targeted to better understand the tumor subtype.
So if you have additional questions but are either feeling shy or because we're out of time, if you could tweet them, we'll try and get answers to you through that mechanism. So thank you very much again, Dr. Simard. Oh, we'll sneak one more in.
I just wanted to ask you a question that a lot of people ask me. The HRT additional risk. Now, there's a lot of people out there that say, rather than it being a group effect, the bioidentical hormones are different. Can you comment on that for me?
This is a very interesting topic. My background is endocrinology because I was working on hormone and breast cancer. I did some publication on some molecule which helped the plant to grow. And in fact, when we use these molecule and we test in breast cancer cell proliferation, they increase the breast cancer cell proliferation. Then it's a delicate question. It depends also upon the different type. But if, and also each tissue possesses different type of enzyme which will metabolize the different compound. Some of them will metabolize the product more quickly, other less quickly. And it's difficult. Then you can have a positive impact using this, and maybe not at the breast, but you will not observe the estrogenic effect at the breast level, but you will observe some estrogenic effect on other like on the brain or other region. Then this is a topic which is interesting. We call that endocrinology. It's now in the textbook. We work on that with my colleague at Quebec City during 30 years. And it's an interesting issue. But of course, if you observe an estrogenic effect, sometimes it's not because it's not an synthetic estrogen that it will not act as an estrogen at the breast level. I'm not saying that. I'm not saying that. I'm just saying that I worked many, many years on that. It's a huge, there is a complex, but it's different. It's different. But the risk of oral contraceptive, we're speaking about a risk relatively small, in the increase. Sometimes one SNP will increase the risk, one variant, genetic marker, will increase the risk at the same level. Then it's important to combine all the effects together.